Hello everyone, I'm Dr. Deepika. Today we'll be seeing about how to approach a subfertility station in your MRCOG Part 3 examination. What we will be seeing today is tips and tricks to approach subfertility stations, scenarios you can expect, an example, and how to approach, and common mistakes done in subfertility stations and bones, and what would the examiners be expecting domain-wise in subfertility stations, and some of the useful links. So coming to the tips and tricks to approach a subfertility station. In MRCOG Part 3 examination, subfertility is different. It's something different. It is not like a regular station where they come with complaint. You have to ask about complaints, other history, then you have to have a diagnosis and then explain the treatment options. Here they may not have a complaint, or they may have multiple complaints, or they may have some hidden agenda. So let's see how to approach the station one by one. Always go with a good introduction, confirm the role player or the name and age, and always try to develop a good rapport. Introduce yourself. I'm an ST5. I'm the registrar. I'm one of the doctors. And so always explain your role. And then how can I call you? So make yourself comfortable and make the role player comfortable. And ask for concerns in the beginning. So you fix an agenda. In all stations, you fix an agenda. Like you come with this and this. And what is given is there are some tests which I'm going to explain the results with you, and then we are going to explain the treatment options. Are there any other concerns? So there could be some extra concerns, like they may say like I need some contraception for at least 6 months now, or I'm worried about something else, or I know this is the treatment, but I just want to explore that also, or I know this is the treatment for this, I just want to know about this only. So your job is made simple. Assure confidentiality and ask for patient details. So partner's details. So always it is important to ask about the partner. So know if the woman's husband's name is Jim, can you tell me about Jim? Why he hasn't come with you? So it always breaks the ice, and she will talk about her partner, or is there any issues, any worries, any domestic violence. All these will come out. Assuring confidentiality. Always, because subfertility is a condition where they have some hidden issues which they may not open up. There could be some sexual dysfunction, or they may have some difficulties, like they may be socially withdrawn, and there could be some depression. So always, if you share confidentiality, see, I'm here to help you. So whatever you share with me will not be shared with anyone else in the hospital, and it will be unless you ask to do so. So if you assure confidentiality, they'll open up about their condition. And always inquire what they're looking for. May I know what is your concerns? Are you having any other concerns? Then always ask for the LMP. I've seen many candidates, like if a woman comes with difficulty in conceiving, they assume that they've never become pregnant, or probably they may be pregnant at present. So always ask for LMP and rule out a pregnancy. Go for a detailed fertility history, which includes how long they are trying to conceive, how frequently they have intercourse, there any dysfunction, and also are they using any contraception. And menstrual history is always important. Ask about the regularity, flow, any menstrual complaints, and ask for previous pregnancies, if any. Have you become pregnant so far? Now, going to the other important things, like ruling out for the symptoms of PID and whether she had PID before. Partner's support and partner's history, present partner. If any previous partner, you have to ask about the previous partner's history. In specific stations where you are suggesting a surgical approach, you can always ask for blood group and reservations for transfusion. Otherwise, you can always skip this. Asking for BMI, advising weight reduction if appropriate, is very important in subfertility. Never forget to evaluate the male partner. See, whenever a woman comes with complaint, she's done with some tests, and if there is a finding, for example, if there is a tubal block, we get carried away. Some people get carried away and start talking about the all the treatment options, but they wouldn't even have asked about whether the semen analysis was normal or not. That is wrong. Always ask about evaluation of the male partner. And in some special stations like same-sex couple, you have to ask whether they have decided who's the birthing partner. Then family history. Yes, as you know, in subfertility, asking for family history of premature ovarian insufficiency, endometriosis has a role. And signpost and ask for personal history, smoking, alcohol, any drug abuse, and suggest to abstain. Social history, support at home is very, very important. How happy they are, how her partner is behaving with her. It's very important. Check the background knowledge of the role player, the patient, about the condition, how much they know about the condition. And if it is a bad news, break the bad news sensitively. And then always when you're talking about the treatment options, go step by step, 1, 2, and 3. If there are 2, 3 options, tell the options and then go one by one with pros and cons. Ask for contraceptive needs. They may have contraceptive needs at present. So always ask, do you want to delay it? Do you need any contraception at present? And also, if there are some conditions when they cannot conceive at present, if the HbA1c is more than 10, so they cannot conceive at present. So in that case, you can always offer contraception. It is not safe to conceive now. Psychological counseling, putting their concerns in first place is very, very important. And fix appointment with the consultant fertility specialist, because in MRCOG Part 3, the level of competency expected is around ST3 to ST5. So always give an appointment with the consultant fertility specialist. In male stations, in male infertility stations, if there is, for example, if there is azoospermia, always fix an appointment for examination by the male fertility specialist. Okay, so now we will go with the scenarios you can expect. Number 1, you can have a woman who is trying to conceive and not evaluated so far. So they're coming to you first time so there you will have no tests or results. So it will be like a woman who is not conceived for 2 years of trying. Then you have to go and tell about what are the tests which has to be done. There could be the other scenario, like they would have done some tests like tubal evaluation and coming to you. You have to discuss the report. If other evaluation, if a menstrual history is abnormal, you have to talk about the mid-luteal progesterone and ask whether husband is evaluated. Otherwise, husband has to get evaluated. And one thing which is very important in NHS, you have to stick with the word. If she says partner, you use the word partner. If she says husband, you can use the word husband throughout the station. And there could be another station, like if all the evaluation would have been done, everything is normal and they want to know how to take things forward. That is unexplained infertility. And a couple trying to conceive, and if male test is subnormal, like if they have mild oligozoospermia. So you have to talk about how to go about further, when to repeat the tests. And it could be an azoospermia abnormal test, so you have to suggest immediate repetition of the semen analysis. And what could be, if it is azoospermia again, what could be the treatment options? You have to explain with the pros and cons and the success rates in the order. Or there could be some scenarios like everything has been done and they may have, the woman is elderly and high BMI. So you have to take it as an unexplained infertility. You need to talk about advanced treatment like IVF-XC. And you can commonly get PCOS station, hyperprolactinemia. It could be undiagnosed, or you are the person who is diagnosing it for the first time. Endometriosis, yes, rarely you may get with indication for surgery. And there could be a woman with Turner syndrome. So it could be diagnosed, or you have to, if karyotyping is done down when she's coming to you, you have to break the bad news. And you have to talk about the fertility options. Same-sex couple, yes, you can get. So they may be looking for fertility options. So you can always ask whether they have decided the birthing partner. Then you have to stick on to the history with the birthing partner, and single woman looking for fertility options. You can have MRKH syndrome, so you have to talk about surrogacy. You can give an idea about uterine transplantations. It is not available in all NHS trusts. You can always say, I can inquire and let you know. And it's an option, but it is not widely available in all the NHS in the UK. A trans man or a trans woman looking for fertility option. And a woman who had undergone an IVF and presenting to you with symptoms of OHSS, could be of varying severity. This could be a station. And a woman with premature ovarian insufficiency. So it could be breaking bad news, or she knows that she's going for POA and she's looking for fertility options. The list is endless, but I've given you probable stations or common stations which are asked. Now let's see an example, how to approach a station. See, this is a station. So this is the candidate instruction of a station. They'll give you a task, whether it is a simulated patient task or a structured discussion. So your role will be given, what you are. So you have to introduce yourself as this, I'm ST5. And then the patient's name, age will be given, and who has come, what other details. See, in this case, husband's detail is given, and they've undergone. They're trying to conceive for 2 years. These are all the key informations, and they've done some tests 2 weeks back. Why they have come? They've come to know what will be the next step. So what is your task? So your role here is to explain the tests and further management plan, and you will be assessed on information gathering, patient safety, communication with patient, and applied clinical knowledge. And what are the details given? So you're given the patient's details, the serology is done, and HSG is done. And for the man, the semen analysis is given. So what you have to do to start the station is that hello, I'm Dr. Deepika, one of the doctors in the clinic today. May I confirm your name and age, please? This is Erina. How can I address you? Okay. Erina, I can see that you and your husband has done few tests 2 weeks back, and you're trying to conceive for past 2 years. So what we are going to do is, like, you and I will go through the tests, and I will explain to you what these tests mean to you. And at the end, you will be able to take an informed decision regarding the management. How does that sound to you? May I know why Mr. Heaney Williams has not accompanied you? All right. So as I have both your test results, is it okay to explain your husband's test results also with you? Has he given consent? Asking about husband or the partner, and whether the partner or husband has given consent. Verbal consent is enough to explain his result, to discuss his result with the wife or the partner. Is very, very important. So now you start, Mrs. Erina. I've confirmed your name and NHS number. The report belongs to you. What you've undergone 2 weeks back is an X-ray test to test your fallopian tubes, and the test results suggest that your tubes are normal. Now, going on to Mr. Heaney's report, he has given a semen analysis. On a gross analysis appears normal, but when we look into the analysis about how much he is given, how much concentration of sperms, I think the results are a bit difficult for you. Is that okay? Do you want anyone to be with you? Erin, I can see that the volume of the semen which is given is normal, but the amount of sperms in 1 ml and the amount of sperms in the total semen given is a bit on the lower side. Erin, I can also see that the motility of the sperms are a bit lesser compared to the normal levels which is suggested by the WHO. Then so whatever the reply she gives, you wait, and then she may ask, is it right? And she may ask why. Then you take forward something. This condition is called oligospermia, but it is severe. So you have to suggest about repetition, you have to suggest about genetic analysis, step by step. So you have to go and explain step by step. Then you have to ask about male history, and you also have to talk about putting this husband in contact with a male fertility specialist, and also asking about detailed history about the male as much as she knows. And you have to fix an appointment for the husband with the fertility specialist. This is very, very important safety point, and how much you know about how to interpret a semen analysis, and arriving at a conclusion and explaining further. All right, now going on to common mistakes done in subfertility stations. Forgetting about other history. Once you obtain a fertility history, how far you're trying to conceive, how long you're trying to conceive, what is the sexual history, contraceptive history, then some people directly go and explain the result and go to the management part. It is always important to ask about their medical history, any surgeries, allergies, and mental history is very important. Social history, all these are very, very personal history is very, very important. So never forget that. And then give importance to partner evaluation, as I've already told. And some people jump onto the abnormal result first. So explain the normal result also, because don't take it as a trivial one. So you have to make sure that the normal test results as well as the abnormal results are explained. And don't give too much information about, for example, if it is azoospermia, you're talking about CFTR mutation and then Y chromosome deletion, and giving too much technical knowledge. You can say we will do some genetic tests to analyze whether there is a genetic problem. These are some tests. Do not tell too much details to the role player, especially in SPT stations. But if it is in structured discussion, you have to clearly say what are the tests you will do and why it is indicated. And always ruling out a pregnancy is very, very important. And some people skip the sexual history. It's very, very important. And not asking about contraceptive history. So when a couple say that we are trying to conceive for past 3 years, and then we are married for 3 years and not conceived for the past 3 years, they would have used contraception for the past 2 years. So that would be missing. Unless you ask, some women won't say. So the scenario would have framed in such a way that if they ask, only the woman will tell that she has been using contraceptive for these many months. Some don'ts, not only in subfertility. Never interrupt the role player when they are talking, especially in stations like subfertility and urogynecology. When they start telling their problem, they'll be talking sentences and sentences. So never try to interrupt them when they are talking. It's very important. Never be judgmental. Never say that, oh yeah, because of smoking, maybe your ovarian function is reduced. Never say that. Even if they ask, you can say it is one of the reasons, but Mrs. Sarah, I'm really unable to say whether this has caused this. So never put it on the patient or the role player. Never say the couple or the woman that you cannot conceive, because fertility is not like that. Even women who had undergone IVF have conceived on their own later. So say that the chance, you can say that these are the treatment options for you. You can try an IUI, but never say that you cannot try normally, you have to go for an IVF. For example, unexplained infertility, a woman in 40s coming with high BMI, you can always suggest weight reduction, putting in contact with a dietitian and all. Never force. IVF is a treatment option for her, and you cannot say that you will conceive only with IVF. So you can say these are the treatment options. She may ask you, so does it mean that I will not conceive naturally? You can always say that there is a chance that you may always conceive naturally, but the literature says that women who are of your age and with high BMI, they need some treatment. But doesn't mean that you cannot conceive normally. You can always conceive normally. Then never assume that she's not pregnant at present. So always ask her LMP. If her LMP is more than more than 30 days, always go for UPT and rule out a pregnancy. And always ask whether you've become pregnant previously. Have you ever been pregnant so far? And never tell anything which you're not sure about. For example, she's asking you, can I find a sperm donor? Yes, you can easily find, and these are you can always ask the hospital. Finding a sperm donor or finding an egg donor is very difficult, and there's a long queue. So always, if you know about those details, you can always give them the link, and you can give a just yes, finding a donor is difficult. You have to register and you have to wait. The list is long. But if you're not sure, don't say anything which you're not sure about. So coming to examiner's expectation domain-wise, what are the expectations in subfertility stations especially? So if you take information gathering, they'll see whether you're getting a focused fertility-related information and partner history, sexual and personal history sensitive. You have to ask them sensitive. Then information regarding social mental status, and then you have to advise accordingly. If they feel low, depressed, you have to advise them psychological counseling. Check the background knowledge. How much do you know about the condition? They would have read on the net, or the previous doctor would have explained. Signpost before obtaining personal history, and their examiner is looking into your ability to understand the investigations, how much you understand from the test reports given, and whether you're interpreting and explaining the results correctly and appropriately. Communication with the patient, sorry for the spelling mistake. Obtain a structured information gathering, and be non-judgmental about their fertility status or the sexual status, etc. Understand the concerns, why they have come, what are their options. For example, a same-sex couple, they have already made up their mind for IVF. They don't want to go for an IUI. So you cannot at that time say that no, this is the way and you have to go with IVF. So their concerns are important. And acknowledge the problem. If there is a sexual dysfunction, you should be able to pick up that and be empathetic. Signpost before asking personal history. I think it's a repetition. And use patient-friendly language. Don't use jargons like very complicated words which normal non-medicals cannot understand. Interpret the results and explain results in an appropriate way, in an understandable way. Provide a stepwise management plan and provide written information and visual aids. You can always draw and show the womb, how IUIs, you can put a tube and explain that the sperm is put here, the processed or the washed sperm is put here. And you can always put a dish and draw how an IVF is done, how sperms and eggs are put together. And you can always show how the egg is injected inside the sperm is injected inside the egg. You can use a diagram. Coming to communication with colleagues, especially in SD stations, putting in contact with a specialist, appropriate referral, and involving MDT, for example. If it's a male fertility stations, it will be the male fertility specialist, consultant fertility specialist, and if they give permission to write back to GP will be involved. And if it is a trans man or a woman having a sexual dysfunction, it will be the fertility specialist, and it will be the psychosexual counselor who will be involved. So always involve MDT if required. And involve consultant if you have any uncertainty, if you're not able to come at a proper conclusion of the diagnosis. Always, involve the consultant and give information about who all will be involved in the care of their fertility journey. And asking permission, writing back to GP is important. If they're not willing to share the details with the GP, it's okay. You needn't write. Coming to the patient safety, check the patient's identity, check consent of the partner for discussing the result, and this is what is expected. The examiner will have the checklist for each station about all these, and if you have, satisfied all these points, you will get a good mark. Appropriate referral, very, very important. Dietitian, psychologist should be able to pick up, apart from the fertility, high BMI, advanced age, you should be able to pick up all those. And involve specialist. Advise weight reduction program if indicated or if suggested, and advising smoking or alcohol abstinence. And you have to know whether when a woman cannot conceive. It's unsafe to conceive, and you have to offer contraception. And you have to rule out a mental illness or domestic violence. There could be hidden agenda in subfertility also. Coming to applied clinical knowledge, the examiner is checking your ability to understand and your ability to explain the condition, finding, or diagnosis. So whether you're arriving at a proper diagnosis with the information given, recognizing high BMI, advanced age, ability to arrive at a diagnosis, advising on further tests as appropriate, and ability to tell and arrive at what would be the treatment options as one by one, and you're giving the options and you can explain what is done in each treatment option, IUI, IVF, etc. And then how it is done. And you can always probably tell the success rate of the treatment option. Involve consultant and provide appropriate treatment plan, and involving MDT is expected. And you can always give information regarding funding, but you needn't assure. You can always put them in contact with the clinical commissioning group to know about funding. So these are some useful links. And whenever you have a doubt, whenever there is a disparity between a TOG and NICE, always stick on to NICE. Then NICE, this is the link for NICE guidelines, fertility, and HFE, National Gamete Donation Trust, DAISY Network. This all this National Gamete Donation Trust gives information about the donor X. Donation, HFE. In HFE, you get all the information about the your assisted reproductive technology like IVF, ICSI, donor programs, etc. And fertility preservation also. For example, if you have a doubt about donor, when a child conceived out of donor program can contact the sperm donor. So you can, the biological father, you can always have a look into the HFA, because HFA, they're updating regularly. For example, from 1991, they have a registry or information about every fertility treatment through donor. So a child can contact and get the information about the donor, about the even the genetic siblings. They can get in touch. So you have to just go through the HFA. It's very interesting, and you have information about the egg freezing, sperm freezing, embryo freezing, and what are the indications. For example, women, single women and women who are not ready to embark onto pregnancy, they can go for egg freezing. And men in army, armed forces, they have the option for sperm freezing. So just go through the website. It gives you so much knowledge. All right, so this is all I want to say. Subfertility is a different station, but is always a doable. And start with, make it simple, try to understand, take time. If your 2 minutes is not enough, ask permission, just try to get out of something about that and start. When you start, you will be able to understand. Subfertility station is never going to be very difficult if you approach the station with structured history, empathy, and even if you're not able to tell the correct treatment option, it's okay, but your history should be proper, communication should be good. All the best, everyone. Thank you.